Thank you so much. Glad to be part of this really great group going over the comprehensive spectrum of EGFR mutant lung cancer. Here are my disclosures. So this is the outline of what I'll discuss quickly. Mechanisms of resistance. We'll talk about some genomically directed second line and beyond therapies, later line treatment for all comers, histologic transformation, and then a quick focus on CNS metastases. So as my colleagues have really went over, we do have these three treatments for first-line treatment for EGFR mutant lung cancer, two combinations, and of course, osimertinib monotherapy. When we think about mechanisms of resistance, and these are mechanisms of resistance from a tumor tissue biopsy, they can be targeted or subgrouped into on-target resistance, which is acquired EGFR alterations, off-target resistance, which are acquired additional alterations, and then lineage plasticity, which really is histologic transformation to either adenocarcinoma, from adenocarcinoma to squamous cell or small cell lung cancer. But you can see for half of tumors, we really don't have a single gene alteration that drives resistance. I think one way to think about this, and emerging data really looking at transcriptional changes at the time of resistance, is that probably resistance can be binned into two categories. About half the tumors have continued dependence on MAPK signaling and maintenance of adenocarcinoma histology, and then about half of tumors really seem to have dedifferentiation, loss of adenocarcinoma histology, and dependence on this plasticity to drive resistance. And this can likely kind of guide what we do in the first-line setting, but also in the resistant setting as well. So in terms of genomically directed second-line therapies, I think the most well-characterized acquired gene alteration is MET dependence. And this can be, by NGS and looking at MET amplification, IHC with MET high expression, or copy number as well. And so there have been various combinations that have been assessed in this setting. One such combination is osimertinib and tepotinib, the MET TKI in the INSIGHT-2 study, which really showed, good responses and good maintenance or PFS with the combination. And I think interestingly, all of the studies have shown that there is no perfect cutoff for MET positive, but that there is a gradient, and really the higher the better. So the cutoffs that are demonstrating really high MET expression really seem to show the patients that benefit. Excuse me. And then on the right, you can see with savolitinib, similar, where patients that are designated as MET positive have significant responses, and the responses are best seen in that high MET category. These are rare, but if you do happen to see an acquired alteration of a different driver, like an ALK fusion, a RET fusion, NTRK fusion, we have some data from the Orchard study, but also from K-series, where adding in that second TKI to address the second driver can be beneficial. So I think this is a rare occurrence, but something that certainly should be targeted if it is identified. The other sort of, medium bucket is patients with acquired EGFR alterations. There are different acquired EGFR alterations, most commonly C797S, but we also see L718, G724, and these are alterations that make these tumors resistant to these third-generation EGFR TKIs. I think one such strategy in this setting is actually combining first and second-generation TKIs with a third-generation TKI. And this was done in the Orchard study. And there are also case series showing benefit with this combination, as the first and second generations can be effective against these acquired EGFR alterations. There are also fourth-generation TKIs that are currently in clinical development. One such drug is BDTX, the Black Diamond compound, 1535, which showed efficacy in the setting of an acquired C797S. And then the Solaris study is assessing the Blossom Hill compound, BH30643, which again has shown efficacy in patients with acquired C797S. So, for patients in that probably 20 to 25% that have an acquired alteration, those are great strategies, but we need biomarker non-specified targets in the later line setting as well. And so we do have significant data about datopotamab deruxtecan, the TROP2 ADC. This is primarily gathered from the TL01 and TL05 studies that looked at patients with EGFR mutations as well as other AGAs. And there does seem to be an enrichment in efficacy for Dato-DXd in the AGA-positive lung cancers, in particular EGFR mutant lung cancers, where we see significant responses and significant median PFS with the combination. The Orchard study also looked at the combination of osimertinib with Dato-DXd, and this combination was tolerable and did seem to lead to prolonged responses as well. I think, at least in the US, it's important to note that the label does include exon 20 as well as uncommon EGFR mutations for this to be a potential later line treatment. Another such combination is amivantamab with chemotherapy via the Mariposa 2 study. This has demonstrated that the addition of amivantamab to platinum-based chemotherapy, again, improves outcomes with improved response rate and improved progression-free survival. And so for patients that had not received amivantamab in the early line setting, or it's been some duration since the tumor has seen chemotherapy, this could be a reasonable option in the second line setting. And then there are other ADCs that have been mentioned by some of my colleagues that are being looked at in this later line space. Patritumab deruxtecan, the HER3 ADC, was the first out of the gate, but not to the finish line. Izabren is that HER3 EGFR ADC. Teliso-V, another TROP2 ADC, has been looked at, and some of these have been combined with osimertinib, sacituzumab tirumotecan, trastuzumab deruxtecan. So there are these different options in terms of ADCs in the later line setting. And then other chemotherapy combinations. And so I think it's been established that if we are going to use chemotherapy in the later line setting, it is reasonable and compelling to do one of these combination partners. And so the COMPEL study was a study that was presented last year that did stop finished accrual short of its goal, but did randomize patients with non-CNS progression to first-line osimertinib to receiving chemotherapy or chemotherapy with osimertinib. And I think that this study really demonstrated that the continuation of osimertinib does help both delay the time to systemic progression, but also CNS progression. So a potential strategy. And then the HARMONY study, which looked at ivonescimab, which is a PD-1 VEGF bispecific antibody that, again, in that TKI progressive setting, that adding ivonescimab to chemotherapy did improve PFS, but had a non-significant OS benefit. And we await final data from that study. There are other different types of novel strategies that are kind of emerging. There are EGFR protein degraders, and there have been several companies looking at that. There have been radioligands, and so these antibody drug conjugates, the payloads can be chemotherapy, but we can also use potentially radiation to help in that setting. And then, I mentioned that there are, plasticity and dedifferentiation drives resistance, and also is important in that drug-tolerant persister cells in the minimal residual disease setting. So there are also different compounds that are being looked at to help, in particular, eradicate MRD. So again, when we think about mechanisms of resistance, I think, we now have options in the first-line setting, but, we don't know yet fully, but we suspect that the options that are utilized in the first-line setting might drive or change the trajectory of resistance, and certainly changes what we're able to do in the later-line setting. So, for instance, if chemotherapy used in the first-line setting, we might not have platinum-based combinations available in the second-line setting, and we would move on on to potentially Dato-DXd or other ADCs. And similarly, if we use amivantamab in the first-line setting, options like MARIPOSA-2 may be less relevant. So, we choose the best options first, but among those combination options, it does change the sequencing of our different therapies. And then, as I mentioned before, if we bin resistance into those two categories of continued MAPK dependence and dedifferentiation and plasticity, this might suggest different first-line treatment options where we might want to do dual pathway inhibition up front for those tumors that continue to be dependent on MAPK, and using chemotherapy or ADCs in the setting of tumors that are more plastic or will ultimately have some dedifferentiation. And so hopefully some of our translational work will ultimately help us understand biology of these tumors, and we'll be able to personalize care further. So again, to mention histologic transformation. So this is something that can only be identified by a tumor tissue biopsy. So it is important for patients, when possible, at the time of resistance to obtain a tumor tissue biopsy. We can see, that clearly adenocarcinoma histology is present pre-treatment, and then there can be acquired both small cell and squamous cell transformation. And for institutes where we do this as common practice, we actually have been seeing more mixed histology tumors as well, where there's at the time of resistance there might be combined adenocarcinoma and small cell, or adenocarcinoma and squamous cell biology. One thing that's important to note is that there are genomic risk factors for transformation. So patients that have tumors with EGFR, P53, and RB1 concurrent alterations seem to be at enhanced risk for transformation, or about a third of those patients will ultimately go on to have histologic transformation. We can't consider these tumors similarly to how we consider de novo small cell lung cancers, because, as we know, the biology is totally different. There have been retrospective series that have looked at the standard treatments, including carboplatin and etoposide, which have shown that progression-free survival is short for these patients with transformed small cell lung cancer, as well as overall survival with traditional chemotherapy, specifically platinum plus etoposide. And then even for these novel therapies like tarlatamab, we see obviously for de novo small cell that they have significant benefit with these novel T-cell engagers. And there clearly is this tail of the curve where there are some patients that have durable benefit. We did a multi-center review of patients with transformed small cell to look to see if the responses to tarlatamab are similar, and there were 16 patients that had transformed small cell lung cancer, and you can see really only one patient had somewhat durable benefit, but the majority of patients really did not respond to therapy. So important, I think, to include these patients in different clinical trials, or really have clinical trials that focus on these patients, again, because the biology of these tumors are different. So I mentioned that once histologic transformation occurs, that outcomes are poor. So what can we do to prevent histologic transformation? And so because we identified that co-mutations of EGFR, P53, and RB as alterations that predict risk for small cell transformation, we did an investigator-initiated study where we took those patients with triple-mutant lung cancer, actually put in platinum etoposide small cell-directed chemotherapy in addition with osimertinib to see if there were early clones of small cell lung cancer that we could address with small cell-directed therapy. We treated 11 patients on this study, and we actually did not see improved outcomes. We firstly saw that progression-free survival and overall survival were actually quite similar to what we see with standard first-line osimertinib, but I think most importantly, we weren't able to prevent transformation. 4 patients out of the 11 did develop histologic transformation, so similar rates to what we see with standard osimertinib. So clearly there are early drivers of plasticity that are important to target in this space. But again, I think further efforts should be focused on those early drivers. And then finally, to think about CNS metastases, my colleagues have mentioned that certainly EGFR mutant lung cancer is enriched for patients with for brain metastases, and you can see here compared to KRAS mutant lung cancer. So one thing our group wanted to do is to look at what is the incidence and sort of natural history of brain metastases for patients with EGFR mutant lung cancer treated with osimertinib. So you can see on the curves on the bottom left that about 36% of patients with EGFR mutant lung cancer will have brain metastases at initial diagnosis, and over time that continues to increase, and by the 5-year mark, 54% of patients will have CNS involvement. And then similarly with leptomeningeal disease, it's quite rare to see this de novo at diagnosis, but when we get to the 5-year mark, you can see that 12% of patients will have leptomeningeal disease. And then we wanted to see sort of, does the cadence of emergence of brain metastases affect outcome? And so this is curves that look at the hazard risk for mortality, and you can see understandably that the patients that never develop brain metastases do the most poorly, but interestingly, patients that do the most well, but patients who develop brain metastases on treatment actually have the worst outcomes, and patients with brain metastases at baseline or at diagnosis actually have kind of middle of the road survival, really suggesting that it's the tumors that have progression in the CNS on osimertinib that are the most refractory to treatment and ultimately lead to morbidity and mortality. And then we looked at different EGFR alterations to see are there specific mutations that might have have more brain metastases or less or inferior outcomes. And of the patients that have brain metastases, it really looked like patients with atypical EGFR mutations had the worst outcomes. And I think that that's consistent with us knowing that responses to EGFR TKIs in this space really are attenuated. We then looked at sort of different alterations that might be associated with brain metastases, and maybe we saw increased CARD11 amplifications and decreased MDM2 amplifications, but really there was no clear genomic alterations that either drive CNS metastases that were able to be seen. So clearly it's more transcriptionally or epigenomically mediated in terms of this metastatic spread. I think one thing to point out is that we want to do more clinical trials in this space. And so one such study that we did was looking at amivantamab and lazertinib in patients with active progressing brain metastases or patients with leptomeningeal disease. And so these two categories of patients are really the patients that are excluded from typical sponsored clinical trials. But we successfully enrolled this study and treated patients with amivantamab and lazertinib, and we did see benefit even in this specific population, where the progression-free survival of amilaser in patients with brain mets was 5.9 months, in the leptomeningeal disease cohort 8.3 months. And so I think one thing to say that clinical trials in this space are doable and really demonstrate that oftentimes novel therapies that have benefit also have benefit in the central nervous system. And I think when we are distinguishing between different novel therapies, it is really important to consider CNS efficacy as a deciding factor. So one other question is, what's the role of radiation for EGFR mutant lung cancer? I think that there have been several studies that have shown that perhaps there's an improvement in intracranial PFS with radiation, but no clear survival benefit. So in that setting, generally the practice is if patients have small subcentimeter asymptomatic disease, we've done upfront TKI and reserve radiation as salvage therapy. But there likely is a subgroup of patients that probably would benefit from upfront radiation. And when we looked for potential biomarkers or predictive markers, we saw that patients with larger brain metastases, so patients that have brain metastases greater than 1 centimeter, and also patients who do not have a full complete response to osimertinib are likely the ones that are most likely to progress in the CNS over time. And so one such study that we're running is this ICON study where we're taking patients and doing induction osimertinib and then randomizing patients that have a non-CR to osimertinib to receiving consolidative radiation versus continuation of osimertinib. And I think this follows the paradigm of the North Star study and other studies that have really demonstrated that consolidative therapy for systemic disease improves outcomes, and we would expect a similar response to CNS disease. And then finally, in terms of radiation for leptomeningeal disease, I think it's important to consider how can we improve outcomes for this high-risk patient population. And so Jonathan Yang, previously at MSK and now at NYU, did this phase 2 study where he took patients with leptomeningeal disease and randomized them to proton craniospinal irradiation versus involved field photon radiation. And you can really see that outcomes are significantly better in terms of time to treatment progression in the CNS, progression-free survival, and overall survival with proton-based CSI. And then there is an ongoing NRG study that is looking to confirm this data, but just to think of alternative treatment options that really improve outcomes. So finally, in conclusion, I think a minority of resistance to first-line osimertinib can be attributed to acquired single-gene alterations, so we have to look further to really understand the biology of these tumors. If an acquired alteration is identified, outcomes do appear better if we target that outcome. The most frequent alteration being MET amplification. I think in terms of later line treatment options, if amivantamab has not been utilized, it does make sense to utilize that in the later line setting. In addition, we have, at least in the US, the approval of datopotamab deruxtecan and other ADCs being evaluated in this space. I think for histologic transformation, we have to think of this as a new disease subset where we need to find treatments that work in this space, but also think about ways to prevent transformation. And then finally, CNS metastases really are a critical issue. We do need to do more clinical trials in this space and understand the role of radiation. Thank you very much.